Hi, my name is Shea Hogan. I'm an interventional cardiologist and vascular medicine specialist at Denver Health Hospital in Denver, Colorado. I'm also an associate professor of clinical medicine in the University of Colorado School of Medicine and a clinician scientist at CPC Clinical Research, which is an academic research organization affiliated with the University of Colorado. So currently, the main strategies for CLTI include revascularization, which may be either a surgical approach, an endovascular approach, or a hybrid approach in which both surgery is done usually on the common femoral artery, and oftentimes the endovascular approach is below the infrainguinal arteries, as well as obviously risk factor modification and medical management, including antiplatelet therapy, antithrombotic therapy, statin therapy, and lipid-lowering therapy. Well, it's nice that we're finally getting some randomized controlled data in this space. Historically, critical limb-threatening ischemia has been kind of under-recognized and understudied, even though it's a very severe condition that has high morbidity. And so it's great that we're finally kind of looking at these patients and asking these questions about what management strategies are superior. BEST-CLI helped us, with the question of, is surgical approach or an endovascular approach superior in this patient population? And I think, the results were not surprising to most of us who work in this space, in that in patients who can have either approach, if you have your own, vein graft that can be used, you're probably going to have a more durable outcome than an endovascular approach. But, at the same time, a lot of these patients are very sick. They have a lot of comorbidities. And so many patients don't qualify for either approach. And, most patients end up getting an endovascular strategy simply because they're too sick to undergo surgery. In terms of, BASIL-2, the question of infrainguinal disease is an important one because we know that these patients do the worst. If they have tibial disease, it can be very hard to have long-lasting results from an endovascular approach. But in BASIL-2, what we found was that actually an endovascular approach was superior, and that was actually driven mostly by mortality benefit. So I think these trials help us understand that our endovascular therapies are becoming better and better, and that we now have, a pretty competitive strategy either way. But obviously, the most important thing is talking to your patients, evaluating them for surgery. If that's, a possibility, then great, you can discuss that with them. But if not, then an endovascular approach will help. One question that comes up with these patients a lot is repeat interventions. And as I mentioned, these patients are very sick. They tend to have a lot of comorbidities, as I've mentioned, and they spend a lot of time in the hospital. And so having to undergo repeated revascularizations becomes a big deal, because patients spend time in the hospital. That's money spent, that's time spent. Complications can occur from these procedures. And so we really want to try to minimize the amount of procedures that they have to undergo to heal their wounds and salvage their legs. And so the question in our study was, rivaroxaban has been shown to improve more, major adverse cardiovascular events and limb events in patients with PAD who undergo lower extremity revascularization. But the question that we posed was, well, in the sickest population, the CLTI group, was there a difference in effect on rivaroxaban in the surgical versus the endovascular approach? And what we found was that both groups derive benefit from rivaroxaban. So we know that whether you have surgery or whether you have endovascular approach, if you're in the sickest population, you do have benefit on low-dose rivaroxaban. Well, I think, one is that in any patient who's undergone a lower extremity revascularization, no matter how sick they are, if they're not at high risk for bleeding, that you really should be thinking about low-dose rivaroxaban in addition to single antiplatelet therapy in this population, because patients, they'll derive both a cardiovascular and a limb benefit. And so, many times when we think of the sickest patients, we say, oh, maybe they're going to bleed and have issues from that standpoint. But I think the data continues to show that even though these patients are sick, they do derive benefit. That's a great question. I think I think learning more about why patients progress from, peripheral artery disease that affects them when they walk to the most severe stages of peripheral artery disease. I think that is a critically important question, because if we can identify which patients are going to do this, then hopefully we can come up with therapies to modify, that projection for their disease. And I also think obviously, new strategies, new medical therapies, and new equipment to be used in the endovascular space to try to help these patients, because the end result of CLTI is often limb loss, major limb loss, and that's really devastating to patients, and it's also very costly from both a human value standpoint, from a time standpoint, as well as a financial standpoint. So I think developing more management strategies in this space and identifying these patients earlier on are both very critical for research moving forward.